Hi, I am Dr. Dharmesh Kapoor, based out of Gleneagles Global Hospital's facility, Hyderabad. I am a consultant hepatologist and a liver transplant physician based at this facility. I have been looking after the transplant program at this center since the time of its inception in February 2003. This program is one of the largest transplant programs in the country, and this program is credited with certain news in the field of liver transplantation in the form of auxiliary liver transplant, in the form of split liver transplants, and in the form of combined liver kidney transplants. This is also one of the only programs in the country which boasts of long-term follow-up on its transplant recipients, which is for a period of about 14 years or so. The hospital has been caring for patients with advanced liver disease as well as acute liver failure, and in the state of Telangana and Andhra Pradesh, it is the referral center for these patients. Now, the niche area in which this hospital works is that all patients, they actually come through the liver intensive care before they are listed for liver transplantation. So a good number of patients can be salvaged by a very efficient and timely liver intensive care, and you can actually do away without a transplant taking place for such a patient. This is also one of the few programs in the country which is doing both deceased donor liver transplants as well as living donor liver transplants. So almost 75% of our transplant activity is in the realm of living donor transplants, while the remainder is in deceased donor liver transplantation. In recent years, the team has gotten better, the skills have gotten better, and we have been able to discharge our patients really early, much sooner than most other programs in the country or in the world would. Our results are at par with the West, if not better. And then we also are in a privileged space that we can contribute much more to research and innovation in the area of liver transplantation. So this is not just with respect to anesthetic techniques, the surgical skills, but also how we manage these patients in the post-transplant period. So the immunosuppression strategies have really come of age, and we've now started to look at minimizing immunosuppression early on in the post-transplant period. So our entire liver transplant community knows that if immunosuppression is used in a dose that the kidney doctors use, then the liver patients are likely to have a lot of complications in the short, medium and long term. So we are now moving away from the large or high dose immunosuppression to minimizing or optimizing immunosuppression based on the disease characteristics as well as the host profile. So much so that a good number of our patients are now on intermittent immunosuppression, and we are trying to induce what we call in our clinical language as probe tolerance. So probe tolerance basically means give the patient only that much amount of immunosuppression that is bare minimum to keep the graft safe in the host. What we are looking for to do in the future is to have a proportion of these patients to be treated by adoptive immunotherapy. So like I said, that we do about 3/4 of our transplants in the living donor way. So there is a very distinct possibility that you know the donor and the recipient before the surgery takes place, and this is very different from the Western world, where more than 95% of the transplant activity happens in the deceased donor way, and the donor identification is not possible till such time the transplant is about to happen. So what we will be really endeavoring for is to have the immune cells or the immune regulatory cells from the donor to be treated with the recipient's cells much before the transplant takes place, and these cells to be then infused into the recipient so that we could develop a state of tolerance, and such patients would then have a very high chance of coming off immunosuppression in the months and years to come. This is still happening in the experimental stage and in certain select centers of the world, but I think that is something that we can clearly give shape to. And we have the infrastructure as well as the scientific wherewithal to give this a shape, and this is one of the very exciting things that we are trying to dabble into in the times to come. The future of liver transplantation in this country is that we would want more and more deceased donor transplants to happen, the organs to be utilized in an optimal manner, wherever the donor characteristics permit to use one donor organ in more than one recipient, and like I said, to cut down on the cost of immunosuppression through innovation. And this innovation can also help in reducing the long-term morbidity and mortality of our transplant recipients, especially by orchestrating their immunosuppression.